So this presentation will be focused on the first part of about GIST. And GIST is the acronym of gastrointestinal stromal tumor. And first of all, some data about history. And Hirota discovered in 1998 the gain of function mutation of c-KIT in human gastrointestinal stromal tumor with a publication in Science in January 1998. And Joansu treat a woman of 50 years old with tumor, the type GIST, with liver recurrence in 1998, already treated by doxorubicin, ifosfamide, dacarbazine, and also thalidomide. And in March 2000, this woman was included in a clinical trial with STE571, such as imatinib, and she had a very important response rate in this very heavily treated woman. So this case was published in New England Journal of Medicine in 2001. And GIST model is one of the most successful examples of targeted therapy for the treatment of cancer. What about epidemiology? GIST represents 1% of all gastrointestinal malignancy and 20% of soft tissue sarcoma. The incidence is very rare, with 10 to 15 new cases by million of people per year. There is more male than women. The median age at diagnosis is 63 years. Median diameter is 5 to 6 centimeters, and 10 to 20% of GIST are once metastatic. GIST can develop in any portion of the gut wall, but in submucosa or in muscularis propria. What about histology? The origin cells of GIST are interstitial cells of Kagel, the name of the discoverer. Cells of Kagel are considered as pacemaker, and they regulate peristalsis on the gastrointestinal tract. 70% concerning morphology, 70% of GIST are spindle cell type, 20% epithelioid cell, and 10% mixed type. 95% of GIST are KIT or CD117 positive. 95% are DOC1 positive. DOC1 for discovery on GIST. It is especially important in KIT negative. 70% are CD34 positive. And it is important to research SDHB in case of KIT or PDGFR alpha negative. What is the histological algorithm? If you have a morphological feature compatible with GIST, If KIT positive, it is a GIST. If KIT is negative, you have to search DOC1. If it's positive, it's a GIST. You have to search mutation in KIT or PDGFR alpha, and you have to search CD34. But if DOC1 is KIT negative, DOC1 negative, mutation negative, and CD34 negative, you have to search Desmin or S100. Positive, negative, myogenic tumor. Negative, positive, schwannoma. Negative, negative, consider other tumor. 40% of GIST are located in stomach, 35% in small intestine, 15% in colorectum, and less than 5% outside gastrointestinal tract. And this subtype are called E-GIST. The vast majority of metastases are in the liver and after in the abdominal cavity, and less outside abdomen. 97% of GIST are sporadic, 3% are familial with the germline mutation in KIT and PDGFR alpha. This slide shows you some genetic tumor syndromes. Neurofibromatosis type 1 with an NF1 mutation and characteristic of multiple intestinal cysts. Carney-Stratakis syndrome with a germline mutation in SDH complex genes with gastric cyst at young age plus paraganglioma. And Carney triad, epigenetic SDHC inactivations through SDH hypermethylation, characterized by multiple gastric cysts in young females with paraganglioma plus pulmonary chondroma. What about small cysts? Two types of small cysts. Mini cysts, 1 to 2 centimeters, discovered incidentally during endoscopy, and microcysts less than 1 centimeter, and very often incidentally discovered during postoperative pathologic analysis for other malignancies. Differences between traditional GIST and small GIST is a rate of proliferation very low and different spectrum of mutation, excess of wild type, lower KIT exon 11 mutation, or new mutation. In case of discovery of micro mini GIST, if located non-in-stomach surgery or located in stomach but with high risk future, such as irregular border, cystic spaces, ulceration, echogenic foci, or internal heterogeneity, you have also lead the patient to the surgery. But in case of gastric location without high-risk feature, you can follow the patient periodically by EUS. Knowing the mutational status is mandatory. In 75% there is a KIT mutation, but in 10 to 20% a PDGFR alpha mutation. It is the two main oncogenic drivers. And in 5 to 10% you can have a wild type GIST. All these mutations are mutually exclusive. What about KIT mutation? 11% are exon 9 mutation, but the vast majority of KIT mutation are located on exon 11 in 67.5%, very rarely exon 13, 0.9%, or exon 17, 0.5%. Concerning PDGFR alpha mutation, the most important mutations are located in exon 18 and after in exon 14 on exon 12. 8% of GIST are PDGFR alpha D842V mutation, and this subtype is known to be very resistant to imatinib. So after activation of KIT or PDGFR alpha receptor, there are three different signaling pathway. The first one is a RAF-MEK pathway. The second one is P13K P10 AKT pathway, and the third one is a STAT3 pathway. If you have a wild type GIST, so without KIT or PDGFR alpha mutation, you have to research SDH mutation, SDH for succinate dehydrogenase, or a RAF-RAS mutation, or a NF1 mutation, or neurofibromatosis. A new entity is a quadruple wild type with KIT, PDGFR alpha, SDH, and RAS, but also BRAF NF1 pathway negative. It is a more indolent subtype. It's a unique group with a genomic profile profoundly different from KIT, PDGFR, or SDH mutated, with overexpression of molecular markers such as CLA, CRL, and COL22A1, and also with specific oncogene, including tyrosine cyclin-dependent kinase, and TRK2 and CDK6, and also one member of the ETS transcription factor family, ERG. Surgery is the gold standard of treatment, but be careful, the tumor is very friable, so it is important to avoid violating tumor pseudocapsule or causing tumor rupture. In case of tumor less than 2 centimeters, and so small GIST, we have already seen what to do. And in case of 2 to 5 centimeters, probably laparoscopic wedge resection is good, but with a protective plastic bag. It's mandatory. And with a tumor more than 5 centimeters, laparoscopic or open surgery, but be careful of the risk of tumor rupture. The role of lymphadenectomy is very limited because the risk of lymph node involvement is very low. But some exceptions are SDH deficient tumor. What about positive margin? The definition of negative margin is R0. And the fact you have a negative margin in other tumor than GIST lead to a lower rates of local and systemic recurrence and lead to better overall outcomes. We have some data on breast, rectal, gastric, and soft tissue sarcoma. But what about positive margin in GIST? This paper, very good paper, published in 2012 on 815 patients with 8.8% with R1 resection. Look at the analysis of risk factor and tumor recurrence according to positive margins. You can see that the recurrence-free survival in the placebo group, it's not difference between R0 and R1, p-value 0.24, and the recurrence-free survival in the imatinib group, we have the same result with a p-value of 0.73, so not statistically different. So what are the conclusions in case of R1 or positive margin? Discussion in a multidisciplinary care team, perhaps surgical re-excision for patients in whom the margin clearly identified and resected without significant morbidity, and perhaps a decision to observe versus initiate adjuvant imatinib based on an assessment of the overall risk of recurrence. Surgical metastasectomy could be an alternative option, especially in GIST resistant to imatinib, such as PDGFR alpha D842V, or could be an addition to therapy in the case of surgery following stabilization or response to imatinib. The greater the bulk of disease present, the shorter the time to progression. Decreased likelihood of imatinib-resistant clones emerging when there is a smaller tumor volume. A small paper published in GCO in 2008 on the surgical management of GIST after treatment with imatinib. And there is difference in terms of overall survival between stable disease or limited disease progression and general disease progression in the second group. The overall survival is worse in the general disease progression in comparison with stable or limited disease progression before surgery. So if you have a stable disease after imatinib, perhaps surgery. In case of limited disease progression, TKI plus surgery. But in case of generalized disease progression, only surgery only if symptoms. And in case of liver metastasis, don't forget other local modalities such as embolization of radiofrequency ablation. What about response evaluation? We have different criteria for response. RECIST is based on tumor size and choice is based on tumor density. On CT scan, MRI of contrascendence US. Why it is necessary to have different criteria for response? Because some anti-tumor activity leads to tumor shrinkage, but sometimes there is change only in tumor density. This paper published in GCO in 2009 on 946 patients looked at the overall survival according to onset partial response in the left side of the slide. And in the right side, it is the overall survival according to the best response. In yellow, complete response plus partial response, and stable disease in blue. No difference between these two curves, but difference versus progression disease. So all kind of response, complete or partial, with the exception of progression disease, is a response. Joy criteria based on tumor density. We have some definition: complete response, disappearance of all lesion, no new lesion. Partial response, a decrease in size of equal or more than 10%, or decrease in tumor density more or equal to 15% on CT, no new lesion, no obvious progression of non-measurable disease. And stable disease does not meet the criteria for complete response, partial response, or progression disease, and no symptomatic deterioration attributed to tumor progression. And progression disease, it is an increase in tumor size of more or equal of 10% and does not meet criteria of partial response by tumor density on CT. New lesion or new intratumoral nodules, or increase in the size of the existing intratumoral nodules. This paper, this article published in GCO in 2007 on 40 patients, compare the response rates between RECIST criteria, FDG, PET, or CT, based of the Choi criteria. And we have 43% based on RECIST, 83 with PET-CT and 80% of response rates with CHO criteria. FDG PET is very highly sensitive in early assessment of tumor response. This little slide in this slide show you the functional imaging after 1 day of imatinib. PET scan could be interesting in case of doubt or in case of early prediction of response in the neoadjuvant setting. This slide shows you two pitfalls. Appearance of new lesion may be due to their being more evident when becoming less dense. And pitfall number 2, increase in the tumor size but decrease in density and FDG uptake reduce. What about metastatic disease? In 2002, we have some result of response rate and median OS with different types of chemotherapy. And we have a response rate around 8.3% and a median OS around 20 months. This bad result are probably explained partly by the frequent expression of multi-drug resistant protein and by glycoprotein. And in the beginning of 2000s, it was the arrival of imatinib, also named Glivec. It is this drug targets BSA-ABL, KIT, PDGFR, and ABL with half time in blood of 16 to 18 hours. Absorption from the gastrointestinal tract more than 98%. Metabolism by liver. This drug has to be taken with or without food. This drug, imatinib, is a perfect model for addiction to oncogen, the Achilles heels of cancer. It's a good example. In the left, is the right side of the slide, you have the cancer cell with different oncogene A, B, C, D. And in case of the disparition of oncogene A, the cell is so linked to this oncogene that when this oncogene disappears, the cancer cell transform in differentiated cell and leads to apoptosis. A very old trial published in 2003 was one of the more early phase 2 trial with imatinib on 51 patients with complete response is 4% and partial response 67% for GIST, and in comparison, no complete or partial response in sarcoma, soft tissue. So it is the beginning of the beautiful way of imatinib in GIST. So the next trial is a B2222 trial. It is a phase 2 trial on 147 patients first published in New England in 2002 with a follow-up of 9 months, and after republicated in 2008 in GCO after a follow-up of 71 months. The results are in terms of burst response and partial response, 68 versus 65, and when you combine all the reasons, around 66% of response with imatinib, and median OS around 60 months. Next trial, the phase 3 trial of ERTC that compare 40 milligram twice daily or 4 milligram once daily. In terms of PFS, a slightly better rates of 56 against 50% in favor of 400 milligram twice daily, but no statistical difference between the two doses in terms of overall survival, but a very different curve between imatinib and doxorubicin. Other trial, S0033 trial, phase 3 trial on 746 patients, comparing imatinib at 2 dose level in a resectable or metastatic GIST published in GCO in 2008, with no difference between the 2 dose level in terms of PFS or overall survival. So, what is the optimal dose of imatinib? We have the result of the MetaGIST trial published in GCO in 2010, based on a meta-analysis of 1,640 patients with a follow-up of 45 months, with mutational status known in half of the patient, and 10% of the patient have a primary resistance. And in terms of PFS, we have a better result in the 800 milligram group, 19 versus 23 months, with a p-value of 0.04, but in terms of overall survival, no difference between the two groups. But when we look at the PFS or the OS according to different mutation kits, we can see in the mutation kit exon 9, there is a better overall survival and better PFS in favor of the highest dose. That means 800 milligrams. Other trial, the CALC 140105 or SWOC S0033, published in GCO in 2008 on 428 patient phase 3 trial, and we can see the responses according to the genotype. KIT 9, 35% of partial response, KIT 11, 57, wild type 32.8, KIT 13, 40%, but only 2 patients, etc., etc., with 25% of partial response with PDGFR 18, but only 1 patient. And overall survival according to genotype are 60 months in exon 11, 38 in exon 9, and wild type around 40 to 49 months. what is the best length of treatment with imatinib? And we have the result of this very important trial, the BFR 14, published in several papers, in several journals, and this is the Lancet Oncology. This trial is one of the more prominent and informative study, and this trial influenced clinical practice guidelines. It is a phase 3 trial on 434 patients, and it is a randomization after treatment of Gleevec in advanced or metastatic GIST, patient in complete or partial response stable disease were randomized between a continuous arm or an interruption group after 1, 3, or 5 years. And in case of reprogression, they can be retreated by Gleevec. So, in terms of PFS, 1 year PFS, 76%, 3 years PFS, 43%, and 5 year PFS, 26%. We have a median PFS of near 30 months, better than the URTC trial. And the median OS is around 76 months, so better than the B2222 trial with a median OS of 58 months, probably because of inclusion of patient presenting histologically documented GIST and a tumor with lower tumor volume. This slide shows you the PFS at 1, 3, and 5 years according to interruption or not. And in all the years, there is a benefit in the continuation arms. And so the rate of secondary resistance decreases with a longer duration of imatinib treatment because the 2-year PFS is 62, 80, and 100% in the interruption after 1 year, after interruption after 3 years, and interruption after 5 years. This slide shows you the PFS according to response before randomization. Complete response, median PFS 10 months. Partial response, median PFS 6.1 months. Stable disease, median PFS 3.2 months. So the quality of tumor status at randomization influences the time to progression after imatinib interruption. PFS after imatinib rechallenge according to prior imatinib-free interval. And the green curve is more than 12 months, the red curve 6 to 12 months, and a blue curve less than 6 months. So patients who progress rapidly after imatinib discontinuation has a poorest prognosis and had progression disease sooner under imatinib rechallenge. And this slide shows you the OS according to time to secondary resistance after 1 year, after 3 years. Imatinib interruption did not appear to have an impact on the time to secondary resistance. 2-year PFS rate were similar between interruption and continuous. What about median OS according to KIT genotype? In black or blue, the exon 11 mutation, median OS not reached, and in blue, in red exon 9, and in green wild type, with a median OS around 55 months. And same result in terms of median PFS according to KIT genotypes, with median PFS of 39 in exon 11 and around 12 months in exon 11, exon 9 or wild type. PFS according to KIT exon 11 mutation position in 556 median PFS 49 months, 557 and 558 30 months, and equal or more than 559 63 months. So level of heterogeneity in the nature and topography of KIT exon 11. In terms of overall survival, according to KIT exon 11 mutation position, no difference. And the 2-year PFS, according to quality of resection of up from surgery, no difference between no surgery and surgery. Imatinib is a standard treatment even in metastatic patients with complete resection of all lesions. And extensive surgery of metastatic GIST at the time of diagnosis provides no survival benefits. So surgery as a primary approach to metastatic GIST is not recommended. And last information, 1-year PFS according to quality of resection in patients with excision of residual disease following maximal response on imatinib. R0, R1 in responding, 1-year PFS 94, no surgery, 1-year PFS 70%. So there is some evidence on the benefit of this surgical excision of residual disease following maximal response on imatinib. So imatinib should be continued indefinitely. Treatment interruption is generally followed by relatively rapid tumor progression in almost all cases, even when lesions have been previously surgically excised. So there is some exception in elderly responding patients where toxicity are higher than clinical benefit. In young female in long remission with a wish of pregnancy and a low tumor volume. In patients developing second cancer, where prognostic or treatment is more relevant than GIST, or patient benefiting from a local regional treatment in long-responding oligometastatic patient under imatinib, or in case of unexpected severe adverse event under imatinib. We have some article about pharmacokinetic and dosing of imatinib in the plasma. The example of stomach and small bowel. And the goal of this dosing are tailor imatinib dose. In case of progression disease on 400 milligrams and confirmation to increase the dose to 800 milligrams. In case of unexpected toxicity, and in case of patients with concomitant medication which put them at the risk of major interaction. Side effects, 70 to 80% leukopenia, 35 to 45 anemia, 60 to 75 periorbital edema, diarrhea, 45 to 50%, fatigue, but also less frequently, nausea, muscle cramps, leg edema, anorexia, rashes. Second important drug in the GIST treatment is sunitinib, called Sutent, targeting VEGF, KIT, PDGFR, CSF1, FLT3, RET. Half-life in blood, 40 to 50 hours, and metabolism by liver. And the treatment could be taken with or without food. The FDA approval was based on this phase 3 trial published in Lancet in 2006 on 312 patients in progression after imatinib, and the comparison was between sunitinib and placebo. And in terms of time to tumor progression, sunitinib 27.3 weeks and placebo 6.4 weeks, p-value less than 0.0001. And overall survival are statistically difference in favor of sunitinib, also with a p-value 0.007. Another phase 2 trial looked at the results on a phase 2 trial in 60 patients, article published in European Journal Concern 2009, with an alternative schedule of sunitinib with 37.5 milligram in continuous. And we have 17% of partial response, 67% of stable disease, and a median PFS around 34 weeks. The down part of the slide show you the difference between the continuous daily dosing, median PFS 35.1 weeks, and intermittent dosings, 50 milligram, 4 weeks on, 2 weeks off, 24.1 weeks, but no formal comparison between the two schedules. So a continuously dosed daily oral regimen with 37.5 milligram is effective and well tolerated, although no formal comparison has been done, so no randomized clinical trial. This schedule could be an alternative on an individual basis. What to do in case of progression of the disease on imatinib 400 milligram, sunitinib, or imatinib? This trial look at the response to treatment after crossover from 400 milligram to 800 milligram, partial response 2.3%, stable disease 27%, trial based on 133 patients. And this article published in Oncotarget in 2015 look at the imatinib dose escalation versus sunitinib as a second-line treatment in KIT exon 11. It is a retrospective analysis on 123 patients, and the time to progression was 10 in favor of sunitinib in comparison with 5 months in imatinib 800 milligram. But no statistical difference between the two arms in terms of overall survival, with a p-value of 0.883. In the case of progression disease on 400 milligram, an option may be to increase the imatinib dose to 800 milligram daily, with the exception of insensitive mutation, PDGFR D842V wild type. And dose escalation is particularly useful in the case of KIT exon 11 mutation. And what about side effects? Fatigue, 34, diarrhea, 29, skin discoloration, 25, hand-foot syndrome, also hypertension, hypothyroidism, anemia, and leukopenia. And the last drug approved by FDA or EMEA is regorafenib, called Stivarga, targeting VEGFR, KIT, PDGFR, RET, RAF1, BRAF, FGFR, and half time in blood, 30 hours, and metabolization by liver. And this drug could be taken with water and food with low fat. And the dose is 400 milligrams, 4 capsules by day, 3 weeks on, 1 week off. The approval is based on this phase 3 trial on 199 patients, the GRID trial, that compare after failure of imatinib and sunitinib, regorafenib, or placebo on a phase 3 trial published in Lancet in 2013. In terms of PFS, p-value less than 0.0001 in favor of regorafenib, 7.4 versus 1.7 months, but no difference in terms of overall survival, probably because of the crossover. And concerning side effect of regorafenib, we have a hand-foot skin reaction, hypertension, but also diarrhea and fatigue. Thank you.